Ornithine Transcarbamylase Deficiency is the most common urea cycle disorder. In contrast to all other urea cycle disorders, Ornithine Transcarbamylase Deficiency is X-linked recessive disorder. And the major feature of this disease is inability to eliminate free ammonia molecules in the blood. So let's discuss the pathogenesis of this disorder in details. As we know, when we consume proteins, they are degraded to amino acids, and one of the amino acids is L-glutamate. Once L-glutamate comes to the blood, we convert L-glutamate to carbamyl phosphate, then to N-carbamyl L-aspartate, after this to dehydroorotic acid, and then to orotic acid. To convert orotic acid, we require a specific enzyme called UMP synthase. This enzyme provides conversion of orotic acid to uridine monophosphate. Uridine monophosphate we use in pyrimidine biosynthesis, and pyrimidines we need to produce DNA and RNA molecules. And we know that we need DNA and RNA molecules for cellular replication, which determines the normal growth of organism and normal neurological and physical development. And one of those cells that require DNA and RNA molecules are red blood cells. More precisely, we need DNA and RNA molecules to produce red blood cell cytoskeleton. After this, we produce hemoglobin molecules, and when we combine red blood cell cytoskeleton and hemoglobin, we get normal red blood cells.
Oh, that's cool!
In addition to this, we have to know that during the normal metabolism, our tissues produce byproducts. It's carbon dioxide, which is a byproduct of cellular respiration, and ammonia, which is a byproduct of amino acids catabolism. And to eliminate them, we have urea cycle. We bind carbon dioxide and ammonia with formation of carbamyl phosphate. And carbamyl phosphate enters into the urea cycle by binding to ornithine. This reaction is catalyzed by a specific enzyme called ornithine transcarbamylase, and the byproduct of this reaction is citrulline. After this, we convert citrulline into arginine succinate and then to arginine. And from arginine, we cleave urea molecule, and by this we convert arginine back into ornithine. And this chain of reactions we call urea cycle.
With all due respect, what the fuck are you talking about?
But in some people, mutation occurs which disrupts the production of ornithine transcarbamylase. Without this enzyme, carbamyl phosphate cannot enter into the urea cycle. First of all, this causes accumulation of carbamyl phosphate and ammonia in the blood. Hyperammonemia leads to hepatic encephalopathy, and hepatic encephalopathy will manifest as asterixis, confusion, and somnolence. But in addition to this, accumulation of carbamyl phosphate in the blood will cause increase in production of N-carbamyl L-aspartate, increase in dehydroorotic acid, and as we see, the level of orotic acid will increase. Orotic acid we excrete from the blood by the urine, and in this case, increase in orotic acid level in the blood will cause increase in orotic acid concentration in the urine, and this condition we call orotic aciduria.
What?
The third feature is that, as we see, without ornithine transcarbamylase, urea cycle cannot function. As a result, we cannot produce citrulline. Without citrulline, we cannot produce arginine succinate, and thereby we cannot produce arginine. And without arginine, we cannot make urea. So the level of urea in the blood will decrease. And increase in blood ammonia level, combined with decrease in urea level, is the signature feature of this disease. And the last feature that we have to know is that ornithine transcarbamylase deficiency do not cause megaloblastic anemia.
All right, let me explain something to you, Mr. Black.
The reason is that in this case we have a lot of orotic acid, and there is nothing wrong with UMP synthase, which means that in this case patient will have a lot of UMP molecules. This permits to produce sufficient amount of DNA and RNA molecules, and this provides normal production of red blood cell cytoskeleton, and thereby patient will have normal production of red blood cells. So in this case there will be no macrocytic anemia. Why it's important? Because we have another condition which causes increase in orotic acid concentration in the urine. This condition called orotic aciduria. But in orotic aciduria, patient will have macrocytic anemia, and his blood ammonia level will be normal, and blood urea level will be also normal. So in ornithine transcarbamylase deficiency, patient will have increased orotic acid level in blood and urine, low blood urea level, and high blood ammonia level. And in case of ornithine transcarbamylase deficiency, anemia should be absent. Here we can see the case report of a patient with ornithine transcarbamylase deficiency. So it's a boy. Why it's boy? Because it's X-linked recessive disorder, which means that this disorder affects male patients. At 6 months of age, he started vomiting after fruits were added to his diet. What's wrong with fruits? Fruits and vegetables have a relatively high amount of proteins. As we see, with fruits consumption, symptoms persisted, he began to lose weight, and because of this, he was admitted to the hospital. On blood analysis, boy had increased ammonia level and abnormal liver function test. As we see, prothrombin time, partial thromboplastin time, and international normalized ratio are all prolonged, which tell us about the disruption of secondary hemostasis. And the most common reason why secondary hemostasis can be disrupted is decrease in production of coagulation factors due to the liver injury. Also, boy had very high concentration of orotic acid in the urine, and we know two conditions that can cause high orotic acid level in the urine. It's ornithine transcarbamylase deficiency and orotic aciduria. So, which condition is it? They analyzed the level of amino acids, and the results showed decrease in citrulline and decrease in arginine level. And because these two amino acids are the components of the urea cycle, this feature tells us about the disruption of urea cycle. And high orotic acid level combined with high ammonia level and disrupted urea cycle are all features of ornithine transcarbamylase deficiency.
I think that's the shit, man.
So, to verify diagnosis, they determined the activity of ornithine transcarbamylase, which was extremely low. So the diagnosis of ornithine transcarbamylase deficiency was made. In treatment, the major problem is to eliminate free ammonia molecules. In order to do this, sodium benzoate was prescribed. The reason is that sodium benzoate is ammonia scavenging drug, which means that this drug lowers blood ammonia level. And also, patients should avoid proteins, simply because with decrease in proteins, the income of amino acids decrease, and thereby the release of blood ammonia level will also decrease. As we see in this case, the mutation which caused ornithine transcarbamylase deficiency was found. Also, they determined that his mother was a carrier, and interesting that she was a vegetarian by choice, simply because meat has a lot of proteins, and consumption of high amount of proteins in her case causes headaches and discomfort that can be explained by the toxic effect of ammonia on brain tissue.
What did we learn, Palmer?
I don't know, sir.
I don't fucking know either.